Hi and welcome to Schein Chats. I'm Pete Gibbons, Decontamination and Microscopes Sales Manager here at Schein UK. Sitting alongside me is Bob Newsome, Managing Director of Dentisan. We're here today at the BDIA annual conference, and we're going to talk about dental decontamination and what you need to know about the Health Technical Memorandum 0105. Thanks for joining me today, Bob.
Pleasure, Pete.
Now that England has had HTM 0105 in existence for 10 years, where do you think the documentation will go over the next 10 years?
I think that's an interesting question because, as you rightly say, we've had this document in play now for over 10 years. And if you remember, when HTM 0105 was first introduced, there were two standards. There was a minimum standard set for infection control, and then there was also a gold standard.
Yeah.
Unfortunately, whilst we've seen, I think, a dramatic improvement in the infection control policy and behaviour within English dental practice during that time, because the gold standard or best practice was not given a deadline, then we haven't seen, we've achieved an improvement, but we've not gone further forward from that improvement and taken ourselves to the next level. And so I'm concerned that the document's last updates were in 2013.
Yeah, they were.
So we're nearly 7 years since we've had any further changes to HTM 0105. And I think any document that doesn't get regularly updated is going to get less attention.
It is,
and that's my concern, that we've stopped improving within industry.
Yeah, and I mean, you say about the minimum standards, and that's what dentists are supposed to be working towards. It leads me on to the next question in regards to its initial aim was to progressively improve those standards as a governed documentation. Do you think it's actually achieved that? Do you think it's achieved its goal of what the Department of Health wanted that document to achieve?
Yes, I think it has, and I think people better qualified than me have said so. I think it definitely raised the base level. That was its original intention, was to raise the overall standard of infection control procedure across UK dental surgeries, and it's definitely done that. The truth is that if I'm a patient, I should expect the same level of attention to detail around cross-infection control, whether I'm in a practice in Bath, Bristol, Blackpool, Birmingham. And I think now, if you were to walk into any surgery in those towns, it would be reasonable to expect that the standard of infection control has achieved that minimum standard. And CQC have certainly helped in weeding out people who chose to be non-compliant.
They have,
and there have been a few high-profile cases over the years of dentists or practitioners that were still not willing to comply, and they've been met with a penalty. So that's been helpful. It definitely has raised the initial standard, but I don't think that it has gone on to take it forward from there, which is the point I made.
And I think that's on the basis that, you know, as you said, we're 7 years on and we still have no further update. We're still working towards the 2013 as far as English dentists are concerned.
Absolutely.
Which is a bit of a problem. So obviously, you know, with obviously that in mind, what do you think some of the challenges are that have been faced by dental members of staff, from dentists to nurses? What do you think some of the challenges that they've had?
Well, I think if you were to talk to any practice manager in a city centre busy surgery, the one challenge that they have or their staff continually has is one of time. They're being asked to do many things, not just cross-infection or decontamination, but there's time pressure within the surgery. And I think some of the areas perhaps that could be revisited are around embracing technology that frees up more human resource time to do other things. One example of that would be the introduction of washer disinfectors within dental surgeries. Interestingly, guidance in Scotland, guidance in Northern Ireland has made both of those countries make that mandatory for dentists. But in the UK right now, in England right now, it's still totally acceptable to do manual cleaning and ultrasonic cleaning. And yet, appropriate use of a washer disinfector can not only reduce the handling of instruments, but it can also free up human resource to do other jobs. I think there's also a big question around handpiece decontamination within the English dental community.
Yeah.
You can't immerse a dental handpiece in an ultrasonic bath. You can't immerse it in a sink of water.
No.
You can use connectors within washer disinfectors to safely decontaminate and thermally disinfect a handpiece. And I think that's an area that certainly needs more investigation.
Yeah, because there's certainly not a great deal of that within HTM. It's a very small section that it states within HTM about the disinfection and the cleaning for dental handpieces. But as we all know, a dental handpiece is probably one of the most infectious, if anything, instruments that a dentist will ever use.
Yeah.
Purely because, okay, it's a non-invasive and classed as non-invasive, but theoretically it's also an invasive instrument, isn't it?
It is, and if we work a lot in general medical instrument decontamination. If I look at Da Vinci equipment and robotic surgical equipment that we're involved in decontaminating within mainstream medical healthcare, those instruments have to go through a thermal disinfection process followed by a sterilization process. And I think if you take that science and apply it into dentistry, it's a reasonable question to say, so how do we today in dentistry safely decontaminate and thermally disinfect our handpieces and subsequently sterilize them? Because again, one of the issues with handpieces in the UK is that anywhere in the world, is that you definitely need a vacuum autoclave to safely sterilize a handpiece.
Yeah.
If you're using a non-vac autoclave to sterilize a handpiece, you're not going to get to all the areas within the hollows and lumens within that instrument. In order to sterilize that instrument, you need to achieve 132 degrees in all spaces within that instrument to know that it's safely sterile. And a non-vac autoclave won't achieve that.
Won't do it.
If you were to do a market research study on the percentage of vacuum autoclaves still in the UK dental industry, I think you'd find there was a significant number still in play. Yes. And that's a challenge then as to how we sterilise our handpieces.
There is definitely I know, and we definitely see that as a distributor. We definitely see that. Me, you, and I, with a lot of the education courses that we've done, we've definitely seen it over the time that it is very much non-vac driven market.
Absolutely.
So in terms of looking at that whole market, can you tell me of any insights that are happening in terms of the research that's going on within Decon? Is there anything that's happening?
In 2017, HTMO 101, which is the guidance document for the clinical decontamination of surgical instruments in mainstream healthcare, they upgraded their guidance to say that in terms of protein that's detectable on surgical instruments, they've reduced the permissible level of protein to 5 micrograms or less per side of instrument. Now, in dentistry today, if you clean and decontaminate an instrument, the method upon which HTMO 105 requires you to inspect that instrument as being clean or not is the human eye.
Yes.
And the human eye under a illuminated magnifier.
Yeah.
Okay. In mainstream surgery, the permissible level now sits at 5 micrograms or less per side. So they've introduced a measure. The reason for that is that protein, and specifically prion protein, is particularly adhesive to stainless steel.
It is, yeah.
And so there's a real concern about the transmission of prions from one instrument, from one user to another. And I think one of the areas, therefore, that dentistry could look at, because there's a whole vast use of stainless steel instruments in dentistry,
there is
to look at introducing a permissible level for protein detection in dentistry.
Yeah.
And I see that as being something that is likely to trickle down from 0101 ultimately into 0105.
Yeah, and there has been a lot of talk about that happening. I know I've certainly heard it. Some could say it's Chinese whispers, but I certainly have heard it within dentistry, and it makes complete sense.
Absolutely.
That happens because of the nature of the dental handpieces.
Yeah.
So it makes perfect sense. Brilliant. Thank you again, Bob, for taking the time to chat with me today, and to our viewers for tuning in. We'll see you again next time on #ShineChats.